नहीं आ रहा है। देखो मेरा आवाज आया ना।
हेलो। हाँ अभी। हेलो। हेलो। आ रहा है ना? हम्म।
Hi everyone, those who have joined in. I hope my voice is clear. Please, can you give in your feedbacks? Is my voice, Rahul? Can you check your voice as well if the voice is clear?
Yeah. Can you all hear me?
Rahul, we cannot hear you.
Sorry.
We cannot hear you.
Can you hear me now? Can you hear me?
Hello. By the time Dr. Rahul
Can you hear me
gets
now?
his volume back, still we cannot hear you. We will start with your introductions. We at present have three
Is it
attendees
better?
in the room: Dr. Amruta, Dr. Mrunali, Dr. Tanya. Welcome everyone. If you could just type in your short introduction on in the chat box.
Can you hear me
When
now?
you're typing in the chat box,
Can you hear me, Pratik?
we still cannot hear you, Rahul. So when you're typing in the chat box, make sure that you are selecting all panelists and attendees, and then you can just type in. So presently, I am just going to allow you all to talk so that we can have an interaction with each of you right now.
Can you hear me now? Pratik, can you hear me?
Still not audible.
Can you hear
I
me?
think it is the connection of your microphone. Just check that once.
Can you hear me now?
Good morning, Dr. Tanya. Where do you practice, Dr. Tanya, if I may ask?
Hello. Hello.
Hello.
Good morning, sir.
Good morning.
Sir, right now I'm working in Triple MCN Hospital, private
Oh,
hospital,
okay.
working in Solan,
Okay.
Himachal
Nice to
Pradesh.
hear that. Nice to hear that. So, are you already practicing dental implants, doctor?
No, right now we are not doing that.
Okay. All right.
Yeah.
So,
Yeah.
anything specifically that you're
Can you hear
looking
me
up
now?
to in this webinar? Yes, you are audible now, Rahul.
Am I audible now?
Actually,
Yes, yes. Yeah, Dr. Tanya, anything specifically that you're looking
no,
up to?
sir. No, sir. Actually, not.
All right.
Yeah.
Thank you. Others can also type in their name, place of practice, years into practice, anything specifically that you're looking up to in this webinar. We will be starting at 10:30 sharp. We've started broadcasting this webinar a little earlier so that people can just join in as and when they come. So I welcome you all to this webinar on digital implantology to double your implant practice by giving your patients better experience, better and predictable results, and do everything in an absolutely stress-free environment. Welcome everyone. Myself, Pratik Chheda and Dr. Rahul Shah are going to take you through this entire webinar. Welcome Dr. Anuja to the room. You can just type in on the chat box your name and just introduce yourselves normally so that we can have an interaction going forward. So day before when we did this webinar, it was a pack house. So the chances of having one-to-one interactions were less. But today, as we are not expecting too much of a crowd, we can easily have a one-to-one interaction with all of you and see to it that we can easily cover as much as possible.
Any specific topics people want to cover today more in detail? If you all let us know prior, we can spend some more time on those topics individually. If your mic is not given access, you all need to raise your hands or type it in the chat box.
Only when you're typing in the chat box, make sure that you are selecting all panelists and attendees so that everyone can view what exactly you're typing. By that time, I'll just start sharing the PPT. So today we are not just doing the webinar on Zoom here, we are also live on YouTube today. So if any of your friends want or would be interested in watching this webinar, they can also watch it on YouTube. Dr. Radhika will be sharing the link for the YouTube streaming, so that also can be done. I hope, Dr. Radhika, you have also shared the link on the WhatsApp group so that there were some who did not want to attend it on Zoom, they can do it there. So again, I welcome all of you. We have a few more attendees. Welcome, Dr. Gaurav. Welcome, Dr. Nushur, to the webinar. At this point of time, we are being joined in by more and more attendees, which is good to see. Keeps us excited for the entire webinar, keeps the energy high. And for the energy to be high, it is very much necessary that all of you keep on interacting with us continuously. And when there is interaction, it becomes more and more interesting and exciting. And for interacting with us, what you can do is you can use your chat box. Just make sure that you are selecting on all attendees and panelists when you are chatting in the chat box. Any questions that you have during the webinar, you can ask in the chat box or in the question and answer, or you can just raise your hand if you feel you want to talk regarding any problem that you're facing or any questions that you're having during the webinar.
Welcome, Dr. Aishwarya. Welcome, Dr. Saili. Welcome, Dr. Abbas. Welcome, Dr. Amit. So slowly and steadily, more and more participants are joining in. But I think we need to stick to the time, at least 3 more minutes, so that no one misses anything important once we go ahead. Like Dr. Pratik emphasized, it would be nice if people would have their queries or doubts within the course so that it seems as an interactive thing and not just talking to the screen. In these times, people have been used to talking to the screen more than talking to the people in person, but we can change it today.
We are starting. So I think, Rahul, we should at least start building up and begin. By the time it will be 10:30, we'll start the show completely.
Yeah, sure. Please go ahead.
So before we go on, let me do a very important thing, and that is thanking all of you. Thank you so much that you chose to be here today to listen to us and help us share our knowledge and experience with you. The topic for today is going to be digital implantology, wherein you can use the digital technology for the betterment of your patients to give them a fast, precise, and better results. We are still being joined by a few more attendees at this point of time, and that is why I'm so excited today. A warm welcome to all those who have just joined in. And it's 10:30 precisely in my watch, and we are now about to start with the webinar in 3, 2, 1. Let's go.
So friends, we had a packed webinar 2 days back, but at the end of the webinar, we had the feedback session. People told us that the content was very good, but it was less interactive. So today we have decided it to be a little more interactive. If you all feel we are stretching it too much or we are too slow or we are trying to be too interactive, you all can let us know. We'll try to wrap it up within time. Basically, why are we here today again? This is a topic which was considered to be the future, but now has been taken up as present in the last few years. So we'll be starting by saying, do you want to be absolutely stress-free while executing your implant surgeries? Not worry about the angle, the depth, the positioning, or any other critical aspects while doing surgery? Do you want your indirect sinus lifts to be extremely predictable and risk-free? Do you want to always start with the end in mind and have absolute control on your prosthetic outcomes during implants? If the answer to these questions is yes, then you are at the right place. Today, as we go along, we will be covering a lot of important aspects, mainly why digital implantology.
Now you can control it from your end.
In digital implantology. The scope of guided implant surgeries with case scenarios, clinician and patient advantages and its impact on your dental implant practice volume. And finally, the most important thing, question and answer session. But today, as we are not expecting a full about 90 participants, currently there are about 25 participants. So even if each one has a question to ask, we won't spend more than 15 minutes during the question and answer session. But rather than keeping the question and answer session till the end, if anyone has any questions, kindly feel free to raise your hand or type it in the chat box. Also, during our last seminar, most of the people said that yes, we agree that digital implantology is useful. It will help us in our clinical practice. But the problem was, they were like, how do we move on to digital implantology? What armamentarium we will need? And what would be the cost, the price of doing digital implantology in our everyday practice? So for today, me and Dr. Prateek have come up with something very exciting and surprisingly interesting for all of us. We have come out with a package which can help you start digital implantology at hardly any cost. This is not to make it a offer or anything of that sort, but mainly exciting and something worthwhile attending a free seminar on a Monday morning. Dr. Prateek, could you please take the control? It's lagging.
Okay, no problem. But I think you will have to give me back the controls. Yeah.
Yeah.
All right.
Yeah. So to introduce our speakers for today, I would be introducing my very close friend, a prosthodontist, Dr. Prateek Chheda. But that's not how he prefers to be known. He prefers to be known as a father of an 8-month-old daughter who's still in love with his mother. That's his wife. She's also a prosthodontist, Dr. Radhika Chheda. Both of them are directors of Procare Dental Clinic run in Mulund. He is a foodie, a technology enthusiast, and a hardcore lover of trying to spread his knowledge.
And let me introduce Dr. Rahul Shah. In the similar kind of a way that he's introduced me, he is a fitness freak. I can tell you that he has been into kickboxing and now he's now learning. I think you've learned hoverboarding right now, right, Rahul?
Yeah, that's true.
He is a technology lover like me and an oral surgeon implantologist. He has done real-time navigation surgeries, almost 5 of them for orthognathic surgeries. He's the only oral surgeon that I have seen personally doing digital technology and navigation, real-time navigation, using all of it for his orthognathic surgeries, and the results personally that I've seen have been amazing. And he's now moved to Canada right now to explore more on the navigation surgeries. He is also a co-founder of Digital Dentofacial Concepts. It is a center run by us in Thane near Mumbai, which is equipped with a CBCT machine. It is also equipped with other CAD softwares where we do all the implant plannings. We do printings of the stents, intraoral scanners. Everything is done at the center. It is one of a kind digital center commercially available to be used by all the dentists. So together we have been practicing digital implantology for the last 3 years, and we have done over 1,200 digital guided implant surgeries and around 4,000 units of metal laser sintered and zirconia implant prosthetics. At our center, we have been planning and printing around 50 stents per month, where we harness technology to give fast, precise, and better results to our patients. But things were not always the same. Let me take you 3 years back into flashback. We also were regular dentists, regular consultants, and there used to be always a daily stress of case multiplications. There used to be hours of planning which used to go in for especially for the multiple implant cases or sinus lift cases. And even after doing all of that, there used to be some stress levels during the surgery, because of which we used to also train our associates or our assistants to keep a check on the angulations of our hand pieces, the head, during the implant surgery. More time was spent in the flap raising and the closure than the actual implant surgery. And again, we doing all of this, an oral surgeon would be a better person to tell you. But finally, we as prosthodontists also used to think that we should finish the case with optimum prosthetic health without any repetitions or complications during the surgery. And for all of this, we took a decision that we will be shifting to digital implantology. And if you all are also facing similar problems, you should also take a decision today to shift to digital implantology. Now, throughout our journey, we have made a lot of mistakes. We have learned a lot of things. We have set protocols now for better successful treatments using digital implantology. And so we are going to share with you today whatever we have learned in this few years, so that you start where we are today. You do not have to go back 3 years and start where we were 3 years back. So with all of this, with your permission, let's start with today's first topic of discussion, that is why digital implantology.
Like I said, we'll be discussing digital implantology today. But to get the tempo on, to first get out of the phase where I've been doing a lot of implant for so many years, and I am of the opinion that digital implantology is required to be done for full mouth cases or cases where complicated scenarios are present. I would disagree with most people here. The thing is, currently on the screen, we can see a post-operative radiograph and post-operative OPG, which I would categorize it as a 2D radiograph of an implant placed in the upper canine region. From this OPG, it looks to be a well-placed implants. Its apical positioning, the depth, the mesiodistal positioning, the angulation, all looks good. But it's when we further evaluate it in 3D, it tells us a completely different scenario. To our shock, it's quite horrific to see that the implant might have been seen to be in a very, very good position in 2D. Actually, in 3D, it is missing the most important thing. It's not within the bone. So here, with the help of this example, where to begin with, the two sticks seem to be very parallel in the 2D image. But as we check them in 3D, we realize that they are not just not parallel, they are not even in the same anterior posterior plane. So this is why 3D technology is important. So even if before we move on to digital implantology, it is a must to evaluate all our cases with at least 3D technology, or at least with a CBCT. If we take that step forward, going to digital implantology is just our convenience. So why digital implantology is our convenience, we would try to cover it in today's short webinar. And if there are any further questions, we would be happy to answer them in question and answers or in emails or anything further. And there are comprehensive courses which we conduct, which are spread over 2 to 3 days, where we cover each and every aspect of digital implantology more in detail. If anyone is interested in basic implantology, that also can be covered. But for today's lecture, considering most of us are aware about basic implantology, I would just like to tell you all about an regular implant practice workflow, or generally what most people do when they plan an implant case. As the patient walks in, we first obviously try to convince him to go for an implant. That's when is the most important step, the consultation. I leave that to each and every dentist's uh, skills on how to consult a patient to implantology. That in itself can be a topic worth debating over 2-3 hours. But considering we have done a consultation, patient has agreed to undergo implant, that's when our stress starts of planning the case. What do we do first? We first diagnose it. To do that, we generally use an IOPA or an OPG, which, like I said, are 2D radiographs. To go one step further, we sometimes make impressions and try to imagine what the prosthetic outcome could be. Then we attend few seminars, we attend few lectures, and people tell us, no, it's 3D technology, which is mandatory because there are certain defects which cannot be obviously seen on a 2D radiograph. So yes, we go ahead and take CBCTs. Some people prefer to do bone mapping, but that is a very, very age-old technology, preferably not done because it's invasive. Patient may be having pain when you do that. And some people try to do wax ups so that they are aware of how their final prosthesis could be. Yes, it's time consuming, it's stressful. Then what do we do? After so much of planning, we finally come to the day of surgery. But mind you, what has happened? What we have planned was all on radiographs or on cast, or it was absolutely virtual. We have not planned it actually in the patient's scenario in terms of his bone, his soft tissue, his prosthesis all together at once. So what do? We have planned to put 2 implants. Generally, we keep 4 or 6 implants in our inventory. We call them as standby implants, just in case I open and the bone is, less. Then I'll put a narrower implant. If I have too soft bone, then I'll do one short osteotomy and put a larger implant, so on and so forth. Indirectly, we are increasing our inventory and our cost. Then the final surgery. We raise a flap. We ask our colleague, our assistant, to make sure that my angulation is not changing. We are keeping an eye on the depth. If some people prefer to keep an eye on the angulation, they tell their assistant to make sure that the XYZ ring on the drill, kindly make sure. If someone tries to do that both, then inadvertently they are a little stressed that everything has to be taken care by the one person. And then finally, the stress of suturing. You finish the surgery after half an hour, your adrenaline comes down, you feel relaxed, you're like, oh, the surgery is well done. And then suddenly your assistant will offer you a needle holder with suture, and you look at them and are like, yeah, I still need to suture it up. If you are an oral surgeon or a periodontist or a person who's been well versed with making incision and suturing, yes, this might just pass by. But there are days, in spite of doing long surgeries day in and day out, I get frustrated or tired suturing it up. But it's a very important step. So after all these efforts, the patient is tired. He'll ask you one question: am I done with surgery? Do I ever have to come for surgery again? And you sheepishly tell them, surgery is done, but only thing is you need to come back for removal of these sutures. And the patient is like, what? Do I need to take anesthesia again? Would that be a surgery again? And you are like, no, it's a short procedure. We don't have to do surgery. We don't have to give anesthesia. It's just one suture. We just cut it and pull it out. The patient is convinced. But then comes the second stage. What do? It's a surgery which seems to be a very silly procedure. You cannot charge the patient for it because you have charged lump sum for implants. But still, the incision, the suturing, and the post-operative pain the patient has to bear is going to be there. Then again the suture removal for that stage. Then comes the complicated closed tray, open tray, different techniques of making implant impressions. We do that. We somehow manage the phase of making and right impression. We send it to the lab. Then, because the lab is not very sure of what impression you have made, he would prefer to send you a jig trial. That's when the patient asks you, uh, how many more months would it take to finish my case? And you're like, no, it's just 10, 15 more days remaining because this jig trial is done. Now the lab is sure that everything is fine. Now he'll either make a metal coping or he'll give a zirconia coping, or he might directly give you a BIS trial. Or if you are really in a hurry, you will ask for a final prosthesis, somehow do certain occlusal adjustments and then deliver the prosthesis. So overall, it's a long process. Is it a wrong process? Absolutely not. It is the process which was followed for so many years, and it is a time tested process and nothing wrong about it. But imagine a scenario where you could cut it short by many steps. You could cut it short by less stress. So this is where digital implantology workflow would come into picture. You have to consult the patient, that remains the same. You have to do diagnostics, but here, like I said, we prefer or we insist on doing 3D diagnosis, a CBCT, or in certain areas where CBCT is not available, you can also do a medical CT scan. Both of them generate DICOM images. Like we have JPEG for photographs, we have DICOM for CBCT data. That is one thing is important, and we make impressions. Then we send it across either to a lab or to digital dentofacial concepts, or if you are well versed with your softwares on your own, you can do the digital planning yourself. How long does it take to do digital planning? For a single implant, for a person who's been doing it quite regularly, I don't think more than 15 minutes should be required. Because it's a digital platform, we can share this planning with the operator can check the planning again and again. We can change it 100, 500, 1,000 times, how much ever you want. And then once you're sure, once you're convinced and satisfied with the plan, then we go ahead and print a a 3D printed stent, or what we call a guide. How is it useful to us? That's where the whole fun or the excitement of using digital technology as a clinician comes, because till now what was happening in the lab. Now that you have a stent in hand, how the surgery becomes easy. A very, very important step here is there is a very precise inventory which one can have. What do I mean by precise inventory is, if you plan to place 2 implants, there is 99% of the chances you will need only 2 implants. Why would that be? Because you have spent more time digitally planning. You are sure about each and every aspect of the available bone, even the soft tissue. And also you are convinced that you have planned it prosthetically. So if it is 2 implants, in my experience, in last about maybe 500 to 1,000 cases, I have not carried more than the number of implants I have planned to place, even if I was consulting maybe 100 kilometers away from my clinic. So that is the
Imagine a
level of
case.
confidence I have.
Imagine a case where you're doing an all-on-4 or all-on-6, and how many components we used to need, Dr. Rahul, when we were doing it not the digital way?
I used to need less components. I used to only place implants. So if I was planning to put 4 implants, I would carry maybe 6 or 10 implants. But my prosthodontic counterparts would be carrying about, I don't know, God knows how many number of components, like maybe 17-degree angled abutments, 45-degree angled abutments, 30-degree angled abutments, and with different gingival heights and different impression copings, and God knows, I mean, a very large inventory, which is practically shrunk to less than half when you do digital implantology workflow.
because you exactly know what angulation and what gingival collar you're going to need even for the abutments.
Yes. Then comes the day of surgery. If it's a single implant, just go through this video. It's not been doctored much, as it's a minute video, but if you see the ease with which the implant surgery is carried out, one can appreciate that even if you see it in real time, it cannot take you more than 5 minutes to do the surgery. If if we saw, the first step was a tissue punch, that means no flap. Then we do sequential osteotomy. So say suppose we are planning to put a 4 into 10 mm implant, what I would do first is I would do an initial drill, then I would go to the desired height of 10 mm and then a desired diameter of 4 mm. So practically I will be using a tissue punch, that is one drill, initial drill, that is second, and then 10 three drills, 2.5 mm diameter, 3.5 mm diameter, and a 4 mm diameter. So four drills, and then an implant placement directly through the stent itself. So how much ever time you decide thinking among these 4 or 5 drills, you cannot spend more than 5 minutes. You place the implant through the stent itself. It has humongous number of advantages. Imagine a scenario where it's a soft bone. You have done an awesome osteotomy, but when you're planning to place the implant, suddenly you realize when you're ratcheting the implant, the bone is so soft that the implant position starts moving during the placement of the implant. This is practically negated with the help of stents. And because it's a pre-planned surgery and you have spent enough time planning it, you know where you're putting it. Most of the times, you do not need to take any intraoperative radiographs. If you are not convinced, initially you might take as many number of radiographs, but you will finally have a similar outcome. After a time, you will not take radiographs. Imagine trying to maintain sterilization intraoperatively, taking radiographs during implant placements. This is a particular scenario where the implant was planned to be placed just kissing the sinus lining. And that is what we have achieved with 100% confidence of not breaching the sinus lining or not entering into the sinus.
If you're feeling that this is a wow factor that you can have in your own practices, please type in wow in the chat box so that we understand that we are reaching out to you. And when you're doing that, please make sure that you are selecting all attendees and panelists when you're typing in that. Thank you so much, Dr. Shobaz Dhan. Thank you so much, Dr. Tanya, for that feedback. Keep on giving us the feedback so that it keeps us also excited when we are doing this webinar. Please continue, Doctor.
So this was not the end of the awesomeness, like Dr. Prateek said about the surgery. Because there was no flap raised, there's no need to suture that again. So there's no extra time spent after you tell the patient that the implant is done. Because in my initial cases 10 years ago, I remember when I placed my first implant, I was so excited that once the implant was placed, I was like, ah, implant is done. And the patient was like, wow, can I go home? I was like, no, sorry, we need to still suture the wound and so on and so forth. So actually here, once you remove the stent from the patient's mouth, you have practically finished the surgery. You can ask the patient to bite on a gauze, give the post-operative instructions, post-operative medication, and the patient is all set to go home. So that's how important it is. If you have planned the case well in advance, where you are sure that the type of bone is very good, or you know that it's a very, very straightforward case and you have good soft tissue, then you may not do a second stage. You can put the gingival former immediately on this day one, that is on the day of surgery. So what does that help you? It helps you make an awesome gingival collar, because the gingival cuff has been present for almost 3 months in the patient's mouth. I would not have to insist more on the fact that there is no need of second stage surgery in such cases. So obviously no pain, no local anesthesia, no suturing, and the time, your chair time is less. The patient is more relaxed that there are not additional surgical procedures.
So,
Coming
Dr.
on,
Rahul, I have a question. How much time generally, if you're doing a second stage before the impressions, how much time do we ideally have to wait before we make the impressions?
we have to ideally wait for 2 weeks, but I have never waited for 2 weeks because the patient is always in a hurry. And then generally we make an impression after a week, and there is always some amount of soft tissue changes which occur after you have made an impression. So you generally have some food lodgement or some problems. So ideally you need to wait for 2 weeks, if I have to answer your question.
We also have a doubt from Dr. Dilip. Thank you for that question. Whether to give a cover screw or directly a healing cap in the case of using stents like this.
See, the basic requirement of giving a cover screw or a gingival former directly would depend on the point where if you have got primary stability. If you are sure that your primary stability is good, only then can you place a gingival former immediately. That is the uh, uh, longevity or the strength of the implant uh, torque you have achieved. Second would be the type of soft tissue biotype you have in a patient. If the soft tissue biotype is good, that means it's a thick biotype, then you can place a gingival former immediately. If it's a thin biotype, it is preferred to do a second stage surgery because you can manipulate the soft tissue the way you want, and you can give a more keratinized gingiva buccal to the tissue if required. Or you might use adjunct grafting procedures to give that. But if it's a posterior, generally you will not face a problem. If you get a good torque, you can might as well place a gingival former immediately.
Is there a reason why we would get better talks in guided surgeries as compared to the freehand surgeries?
Uh, I mean, it is, I do not have any evidence to back it up, but with my personal experience, I would say that the osteotomies are generally done in the same angle repeatedly. You're not widening it by changing an angle by 1 or 2 degrees on the way. Plus, while you're ratcheting, you have not tilted the implant at all. And like I said, it's a more planned surgery prior, so you have done your maths prior to the surgery. So generally, you are much more confident on the day of surgery. So that also helps in making sure that you are following what is to be followed.
Dr. Dilip is still asking if you are placing the cover screw, do you just leave it as it is without giving sutures, or do you give a
Yes,
suture?
yes, yes, yes. If you have seen, generally the widest diameter implant we use in a case where we have done a tissue punch is not more than 5 mm in a clinical scenario. And so the soft tissue punch would be about 4.5 mm in diameter. And to all of our surprises, if you have made a punch hole of say 4.5 millimeters, and there is a blood clot, there is a high chance that the next day morning patient wakes up and when he's about to brush, he can just see the clot on the gingiva, which is almost similar in color, and he'll ask you, did you do the surgery? I don't see any cut in my mouth. I do not see any sutures in my mouth. And within 7 days, when you call up for follow-up, the patient will have complete gingival coverage on that wound.
I
So
remember the same thing happened to one of your surgeries where you had done 6 implants in an upper
yeah,
jaw.
and it was in my consultation practice. So the dentist called me frantically the next day, and like, the patient is little bit concerned, can you send me the post-operative CBCT so that I can share it with the patient, saying yes, really we have put 6 implants. So yeah, moving on, that's not the end of digital implantology. Today we have digital impressions. What are they? We call them as scan bodies, we call them as uh, uh,
Link
impression
abutment.
jigs, we call them as link abutments. There are different names each company has given, but basically what it is a digital impression post. We place it, use our intraoral scanners and just scan that area. So what do we do with that? We save so much of time. We are sure about everything. The lab is sure that nothing has moved from the time you have made an impression and send it to the lab. He will most confidently give you a final prosthesis in tooth supported stents, as in a case where the occlusion is not a problem, and you go ahead and screw or cement your prosthesis.
I think there's one attendee who's raised the hand. Uh, so I think just a minute. Let me just give him a chance to talk. Let's see what is the doubt. Dr. Sukhman Preet, you have been given a chance to talk. If you have any doubt, we can clear it right now. Just unmute yourself before you talk, or you can just type in your doubt in the chat box. Dr. Sukhman Preet. Okay, I think we are not being able to contact. So if there's a doubt, doctor can just put it in the chat box and we'll take it up. Rahul, you can just continue. Sorry.
Yeah. So coming on to the present scenarios in guided surgery, I think Dr. Prateek, since you are the person who takes care of all the fabrication of stents, you would be the best person.
So yes, let's begin with the present scenario. So most of us understood very early that most of our surgeries should be prosthetically driven. I understood when I was doing my post graduation, and we used to get a lot of cases from our oral surgeon friends, and trying to restore them would be a nightmare. So because we understood that, we started pairing up with them even before the surgeries, and we started with using the present prosthesis that the patient already has, or started doing wax ups on the mounted models and giving them a kind of a stent which was a prosthetically driven guide. And we still realize that in 50% of the cases, the position on the occlusal surface would have been okay, but the angulations were still a problem. That was because the radiographic or the bone conditions were not taken into consideration. Next, what we started doing was we had the CBCT of the patient. The entire planning was being done on the CBCT. So what we did was we started with making something called as a radiographic stent. Now, this was also a 3D printed stent where everything, the planning and the designing of the stent was done using a CBCT. But soon we realized now we are having a different problem. The stent itself is not fitting absolutely well in the patient's mouth. Now, that was because there was a lot of noise that used to come during the planning in the CBCT. And the moment we used to try to remove that noise from the CBCT, there used to be some abrasions that were done on the tooth surfaces, because of which it never used to fit well. So now we have a chance where we combine both of them, that is the prosthetic and the radiographic, and we have something which would take prosthesis into consideration, something that would take the bone condition into consideration, and plus have a stent which would fit absolutely well. And how is that possible? You have the intraoral surface scan. It can be a direct intraoral scanning, or it can be directly you make impressions, you have your models ready, and you have a mounted model. You can also send it to any CAD CAM lab who can just go ahead and scan those, and we have the surface scans ready. Once we have the surface scans ready on the CAD software itself, we can do all the prosthetic planning as we have already shown you in the previous video. Then you have the CBCT of the patient. You have a 3D reconstruction of the CBCT. And on this reconstruction, you can plan your implant in 3 dimensions. See, it is very important when, even if we are planning our implants on sections, it does not mean that on a 3 dimension completely on in the volume wise, there will be no localized problems in the bone, which we are not considering at times. Now, even after doing this, it is very important that both of these datas are overlapped on each other to take into consideration the prosthetic and the osseous factors at the same time. You need an optimum balance between both. And when you are doing these two things, you also attain a balance in the soft tissue contours. How is that possible? Because you have the bone, you have the surface scan, so you will easily get what is the amount of soft tissue that you are having in that region. And once you have this balance and you've done all the planning in 3 dimensions, then you go ahead and the designing of the stent is done, which is also very simple process. Now you will ask me if we can do it on our own or we have to approach someone to get this done. See, you can always approach a third party, give them the CBCTs, give them your models, and tell them you plan for us. You will get the final planning at your doorstep, because this is entirely digital. You can always have that planning, look at the planning, and finalize the plan. Once your plan is finalized, then they can go ahead and they can uh, design the stent, print the stent, and get the stent to you. So you do not have to have the entire technology at your end only. If you say I want to plan my own cases, there are softwares available online where you can do the planning, do the designing on your own, and send that design to some 3D printing third party who will give you the 3D printed stent. And if you want the entire technology with you can do that. So this is a workflow that is given by Ostim Implants, which is called the One Guide workflow. One Guide is basically their guided kit that they call it. And this is the workflow. So you need the initially the data, that is the CT scan or the intraoral data. Sorry. Yeah. So the CBCT, then you need the stone model, the bite record, or the intraoral scan. Then the implant planning is done. Then the guide fabrication is done, and finally the guided surgery is carried out. And you can go ahead and at times also give a provisional prosthesis immediately. So what are you gaining here? You are gaining better prosthetic outcome and control, because everything is prosthetically driven. You get precise planning with a complete 3 dimension osseous outcome. You come to know if there are any localized osseous defects. The planning is done with an optimum balance between the prosthesis, bone, and soft tissue. And you also know what kind of prosthesis would you need for this patient, what will be best suited. Imagine you're doing upper anteriors and you do not know whether I'll be able to do a cemented prosthesis or a screw retained prosthesis, because finally what angles your implants will go into depending on the bone availability, and finally how exactly are you going to restore is still question. So in this case, you can solve it because you will know how exactly your implant position is going to be, where exactly your abutment position is going to be, and you can make a decision at that moment whether I will do a screw retained or a cement retained prosthesis, depending on the screw channel axis that you will be getting. You can plan your healing abutments, your abutment collars, your augmentation procedures, everything in this particular scenario. If you are using a digital implant workflow, and if you feel by looking at all of this that this is quite exciting, please type in excited in your chat box so that we understand again that we are reaching out to you. And if there are any questions at this point of time, also you can put it in the chat box. Next, what exactly are the scenarios available if we have to do guided surgeries at this point of time. You have something where it works with sleeves, and you have certain kits which work without sleeves at this point of time. So the ones which are working with sleeves, we call them the first generation kits, where you have a key, and through that key your drill is going to go pass through, and you keep on changing the keys for increasing the diameters of the drills. You have something where there is no keyhole. It is just the sleeve part is already a part of your drill in the form of a cylinder, and that is what passes through the guide hole and comes out. Now there are a lot of advantages that without sleeves would have on sleeves. Now one thing is, when you're doing in posterior regions where you have minimum mouth opening, so you will always have a better flow through, go through the sides of the guide holes rather than from going to from the top of the guide hole, which becomes a problem when it comes to with sleeves. The other thing is, with sleeves it is metal to metal contact, so you have to understand that there is a lot of heat generation that might also occur, which is eliminated when it is without the sleeve. Plus handling becomes better because you do not have to handle the key and the drill at the same time. It is just the drill, you just go in and come out. So Rahul, you can take over
Yeah.
with the surgeries and the different case scenarios that we can do. So can we have a clap, clap, clap for Dr. Rahul? He's doing a superb job, and he's going to take us through all the different case scenarios that can be used.
Yeah, before I move on to the cases, there's one doubt. I think it is pertaining to prosto. What to do if we don't have a scanner? Can we still get a zirconia crown done without the scanner and still continue with the digital workflow?
Yes, you can still do that. Uh, See, the advantage with digital technology today is, as I told you, you do not have to have all the technology at your doorsteps right now. You can always collaborate with third parties, and you can still deliver the best to your patients. So if you're not having a digital scanner with you, you can still go ahead and use your normal way of making impressions. And once you have made an impression, and when you're making impressions, if I'm doing normal impressions, I make sure that I am already doing it with the jig, so that I am sure that the impression post is not going to move in any way. So if we are doing that with once we have our impressions ready, we can always collaborate with a CAD CAM lab and send these impressions to them and get a zirconia milled prosthesis on the tie base. Always can be done.
Yeah, so it wouldn't be wrong to share our secret today that when we started digital dentofacial concepts, we actually owned just a 3D printer. We
Yes.
used to use the online softwares which were available. We paid per case, printed for our own cases, and did it. Eventually, we got hooked on to digital technology so much that we ended up buying a CBCT machine, three more 3D printers, an intraoral scanner, aligners machine, and a real-time navigation machine, which made me come to Canada. So yeah, it's you can start digital technology at any level. You can get in and get out at any level. You do not have to spend on the whole technology the whole day. Imagine a situation where you don't own anything, but you have sent a CBCT and an impression to a lab, and he has sent back a stent to you. You can always claim to your patient that we are using digital technology, and it won't be wrong in any way. We are using digital technology. Isn't that true?
Yes. 100%
Yeah.
true.
Yes. And before I continue, I would like to thank Dr. Joy and Dr. Usha for giving me encouragement, saying that it's going good. So yeah, let's continue to the bulk of the topic today. What is the scope of guided implantology, and where all can we use it? I would recommend that it's better to start any surgery with the simplest surgery, including guided surgery. Here, this is a case of a single implant placed in a molar where there is adequate bone available. It's a 6, it's not too posterior, you can easily access it. Even if you have to make an incision, if you have to suture it, there are not many vital structures around. So overall, a very straightforward case. Why would I have to use digital technology for this? Only one reason, so that we get more and more confident with digital technology. Imagine a case where you start in a full mouth scenario where you yourself are slightly stressed about the case, and then you are using a newer technology. So you are stressed more, something goes wrong, and then obviously we have nothing else to blame but a new technology. But if it was a straightforward case, you are much more relaxed. You can follow all the protocols of digital implantology because you are focusing on that specifically. Even if something goes wrong, you can finish it up in the way you are doing regular implants. So that is why it is insisted that you start with a tooth supported stent or a case where minimal implants are to be placed in, otherwise a scenario where not much of grafting or ridge splits or sinus lifts have to be done. Having said that, can it be used in complex implant cases? Of course, it can be used for complex implant cases. That is the reason digital implantology is being introduced and propagated worldwide today. It can be used for immediate implant placement, yes, with lot of advantages, of which the most important advantage is it can help you place the implants in your desired position. It might be the palatal root in an upper case, it might be a distal root in a lower case, but in a scenario where you plan to place it in a position which is not exactly as the socket of the tooth, you still can go ahead with guided implant surgery. Can I do it freehand? Yes, I can do it freehand, but with my experience of doing multiple implant, immediate extraction implant placement cases, my handpiece tends to slip in either of the sockets. Even if I want to put it inter radicular bone, it will either slip into the mesial socket or the distal socket, and then somehow I would compromise by placing it in as centered position as possible, and then obviously convince my wife, who's a prosthodontist, that it was a difficult case. I had no choice. It was slipping into the distal socket, so I've put it slightly distally. You give a slight mesial cantilever, it will solve the problem. But prosthetically, should have been in the center. This is what guided surgery helps. It helps you place the osteotomy as where you had planned, and also place the implant in the same location. Sometimes we do the right osteotomy, but while we are ratcheting the implant tends to slip in either of the sockets because the bone over there, you are just focusing, or you're just uh, it's the torque is just getting engaged in the on the buccal and the lingual plates. There is no mesial distal wall here. So what tends to happen, it can go little mesial, little distal, and then freehand you have no control. But with guided surgery, you can make sure that it goes to the desired position. And then if you have a good torque, you place a gingival former, there's no need of second stage surgery, and you place the prosthesis. So what we have done, the patient has come for an extraction, you have placed an implant, and after 3 months, you put a scan body, you scan it, give a prosthesis. Patient is shocked. That's how much impactful digital implantology can be on your practice.
Also, with the point that you made, Dr. Rahul, of it not being centered, it might go into the buccal, mesial or the distal in such cases. What happens is the cantilever increases on the other side. Now, when the cantilever increases, most of the times it is this cantilever that makes more and more chances of screw loosening. And that is majorly, we can see it in single implant cases, that screw loosening happens more because it not being on the center of the occlusal forces and the cantilevers being increased. And that is where we have all the prosthetic complications arising later on.
Yeah, I have to agree with you, because obviously after I place the implants, it's either you, my wife, or your wife who deals with the cases. So I'm not very sure the reasons, but if you say it has to be true, I agree.
Rahul, we have a question here. Is this technology that can be used for both the basal as well as conventional implants?
Yes, practically it can be used in either of the scenarios, because finally, if one realizes these stents, they do not understand what company or what type of implant you're putting. They will just guide what you're going to use. So it's a good question asked, because I've heard that people have started using it for endo access openings as well, where there have been calcified canals and they were not sure on what angle to proceed so that they don't perforate either the external walls or the furcation area. And they have used it even to gain access to those specific canal openings as well. So yes, it can be used for basal and conventional. I feel if it's used for basal, it solves the problem much more, because the main problem with basal implants people today talk about is it being a blind procedure. There is no control on where you put it. But if you're doing it guided, then you are getting best of both worlds. You are getting a higher primary stability along with a more planned case.
Should we move ahead? I
Oh
think we've
yes.
answered the question. If the question is answered, Dr. Gaurav, please give us a thumbs up or an okay in the chat
Or
box
if
so
you
that
need any
we are
further details, kindly continue, or we can take it up at the question and answer
later on.
session, so
Yeah,
that we don't break the workflow. Yeah.
yeah.
Again, so can it be used for a case where the teeth were present, and do I have to make an impression, break the teeth in the cast, and then send it to the lab? No, it is not. It's not required today. Digital technology can remove teeth, they can add new teeth, fabricate a prosthesis, fabricate a stent. The advantages being here is, if we see we have extracted 4 teeth and replaced 3 teeth. Why is that important? Because we could tell the patient before we touched him surgically that, see, because of the crowding or whatever, the arch position, the size of teeth which we will be needing post-operatively, we will be able to restore only 3 teeth. So the patient is not at a shock that when you have extracted 4, you're finally giving 3 teeth. Patient feels cheated that something was not done right. But if the patient was explained prior to the case, the patient understands, oh yes, my teeth are crooked and I will finally get straight teeth. Also, if you can see, to much of most of your surprise, it will be that this case, in spite of being a mandibular anterior case, it has been dealt with a screw retained prosthesis. Now, most of you all have placed many implants, and tell me really how many of us have been able to do it with freehand cases. We tend to place the implants exactly onto the bone, and eventually we have to give a cemented prosthesis. So this can be achieved with guided surgery. Moving on to a case where most of us would want uh, to use guided surgery is in edentulous areas. But the patient is not willing for a completely fixed prosthesis and wants to go for an overdenture. These cases, surgically, I have been thinking, are the simplest cases. You don't have to bother much. You put implants anywhere, even if the angle is a little bit here and there, because it's a ball and a socket kind of a situation. The angulation is taken care of, not much of a problem. But actually, after doing a few number of cases and having the prosthodontist in my house who would come and curse me for every mistake I did in my surgery, which led to her prosthetic failures, I've come to know about a very important aspect in overdentures, that the occlusal or the crestal apical position of the implant is of lot of importance, because it can lead to prosthesis fracture if one of the implants is slightly higher than the other one, leading to stress accumulation and fracture. And also, apparently, there is a concept of the inter-arch distance, which will make you decide either you use a ball and socket or a locator type of prosthesis. the cost of locators is much higher than that of a ball and socket prosthesis. And if that had to be incorporated later on during your case, where you had already given a budget to the patient, because it is an overdenture, you had already shrunk your budget, and then you had planned for 2 ball attachments, and suddenly you want to go for a locator, it's an increase in about 5 to 10,000 rupees in your case. And then everything changes. But if you had planned it prior, you knew this case will require locators from the beginning, you could have already added it in the cost of your prosthesis and then planned the case accordingly. So it is very useful in overdenture cases as well. Can it be used for full arch cases? Now, I don't think I need to answer this question, because all of us who have done guided surgery before or have heard of guided surgery before has to be with full arch cases. Not many people have heard of talking about what we have shown you prior this, because they feel that doesn't require much of surgical skills and it can be easily managed. Yes, full arch cases are the prime reason most guided surgeries are done, but I would again insist on a fact: it is better we start with tooth supported cases, at least 2 3, to gain the confidence, know the exact protocol of how doing guided surgery, and then move on to guided surgery. This is a case where uh, guided surgeries were performed and immediate prosthesis was given to the patient. But this is not it. It was done flapless, like you all saw. And in this CBCT, post-operatively, you can make out that there is the implant in the upper right canine premolar region, which is placed completely within grafted bone. Obviously, it was not loaded immediately, but the fact that we could place the implant completely within grafted bone with confidence, with the uh, exact angulation, the desired implant position, in spite of it being as bad or worse than D4 bone. It was practically nothing over there. Finally, the patient walks off with prosthesis, which is as good as final prosthesis. The patient actually turned up 3 months late for his final prosthesis because he was very happy with the temporary prosthesis. Dr. Pratik Chheda, he has done this awesome job of making this photograph for showing how parallel the implants were when the impressions were made. But he had a stress that the patient has not yet come. Will I get the money for my prosthesis? Will I get my consultation chance on this patient? But yes, finally a final prosthesis was made. And if we see this OPG, it's not an OPG, it's actually a panoramic section of a post-op CBCT, one can appreciate that each and every abutment has been seated on the implant passively. There is no place where there is a gap between the abutment and the prosthesis. That just says that this seating of prosthesis was absolutely passive, which increases the longevity of the case. Moving on to a second example where a much simpler case was done, all the implants could be placed as parallel as possible. One can appreciate with the impression posts placed. The holes which had to be made onto the denture were actually planned beforehand, because we knew exactly where the holes are going to be. So I finished the surgery, the impression posts are placed. Dr. Pratik is ready with the holes in the denture. He just places the denture, picks it up, pours his cold cure, makes sure that the temporary abutments are seated, cuts them off, seats this. Patient enters and walks off with 6 implants and final prosthesis with occlusion in 2 hours and 30 minutes flat. From the time I talk to the patient, how are you? Please have a seat. I give local anesthesia. I wait. I put 6 implants. I take 45 minutes. I give him 10 minutes break. Dr. Pratik starts with his prosthesis work. Within 1.5 hours, he finishes everything. Patient walks off of the clinic within 2.5 hours. That is unheard of with freehand surgeries. This is the post-operative radiograph of the patient.
If you feel
Going
that
on.
this is wow, because when I looked at this post-operative radiograph, through though it is a 2D, but still when I looked at it, I felt that wow factor. If you feel the same, please type it in your chat box as wow. This is what you want in your practice.
This is a case where we extracted all the teeth and placed the implants immediately. On the 2D X-rays, they look as if they have placed absurdly in all wrong directions, but that is what we are trying to say. 2D is not a real replica of 3D. It is, if it is seen exactly parallel in 2D, maybe it is not parallel in 3D because our arch curves. So what is seen very parallel in 2D may not necessarily be parallel in 3D. But this case, we can go ahead and show you how parallel it were and how easy it gets to finish the case. Again, the passivity of the prosthesis is what is going to decide if the case was well planned. You put multi-angle abutments and the prosthesis seats amazingly. It is a seamless procedure. The amount of anterior posterior cantilever also is pre-planned in such cases. So you are sure if you're going to give a 5 to 5, you're going to give a 6 to 6 or a 7 to 7 prosthesis. That just makes the planning for the prosthodontist, the planning for the lab much more easier because the patient is sure that
Also,
he's going to get X number of teeth.
Also, the planning helps us in deciding what kind of processes are we going to do. In full mouth cases, especially, there are two options that you can go for. It is metal to acrylic, that is a hybrid prosthesis, or it is metal ceramic or zirconia. These are the options that are available today. So whether it will be a PFM framework or metal to acrylic, how much space do you have prosthetically available? Everything depends on that, and that all can be measured prior if you are doing it in a digital planning software.
Can it be used for single place implants? Yes, it can be used for single place implants. That again solves the query. Can it be used for basal implants? They are single implants, again, just slightly much more longer than these. So it can be used. In this case specifically, the patient already had one implant in the mouth. The patient unfortunately lost an adjacent incisor, and we had to make sure that the second implant is parallel to the first one. So in cases where previous implants are placed, we can put an implant parallel. It be single, it be two piece, it be a crestal or a basal implant, doesn't matter. It is used in cases for ball attachments. Again, one piece implants, you place them and you load them. Generally used in temporary prosthesis kind of situation, but this specific patient, a female patient, not very old, I mean, not very young, an old patient, not going to be able to chew much anyways, had wanted it for retention specifically. That's how we planned the case for her. And this
And
was
with the
what we
kind
could
of
achieve.
atrophy which was there, we've almost planned it till the basal bone only, so that we get
Yes.
the cortical anchorage in the nasal floor mostly.
Yeah. Is it useful in sinus lift cases? So today, we have planned in a case where we are escalating the use of digital technology. We want to show you at the end that some much more can be done. But one casket or a guided digital surgery possible for sinus lift is I feel a game changer for maxillary posterior regions. Imagine doing your osteotomies and putting an implant freehand. Like I said, the implant might get sucked into the sinus. You can have unwanted complications. But if you could do the entire sinus lift guided, you don't need me to come to your clinic and help you do your sinus lifts anymore. You do not have to pay me anything extra. And if you go through our presentation and if you go through our cases closely, you will realize not all cases will require grafting as well. I will explain the reasons as we go ahead. But basically, how does it work? You place the stent, you do a drill just short of the crestal lining. You use either hydraulic or your osteotomes to lift the lining up. You place the graft if required and place the implant through the stent itself. There is no need to remove the stent during implant placement either. So you have complete control on everything. Most people have told me that CBCT data is wrong, that CBCT is not ideal sometimes. I have, it shows 5 mm of bone, and when I start doing the surgery, it actually is 7 mm or 9 mm. So why does this happen? We see, say, 97 mm marking on the CBCT and we start the case. But what are we actually doing? Instead of putting it exactly perpendicular to the bone, we are changing the angle slightly, and the same bone which is there now becomes 7 mm. And we start cursing the CBCT center or the CBCT or 3D technology. But it is not true. If you change the position by even 2 millimeters, you might get extra 2 to 3 millimeters of bone, but that is not where we had planned to put the implant. So this is how, in a specific scenario, the bone changes. It is not the fault in the CBCT. If there was a fault in CBCT, it is practically impossible to replicate what we have replicated. The above line shows us how we had planned the case, and the bottom line is post-operative CBCT of the same patient. And one can appreciate, if we have followed the guided protocol, we could just enter the maxillary sinus only in the distal aspect of the implant. No need of putting any graft, no need of using any sinus lift, because we are just kissing the sinus lining. This is the amount of confidence you will achieve once you start doing guided surgery. If
And
it's
to
a
give
case,
and to just give a little bit about this patient, it was my patient when the patient used to come back repeatedly when he had a post-and-pour in the same region. And finally, we decided to get rid of that tooth. And this was amongst our first cases when we just started with the guided surgeries. And till date, this patient has not even returned once for any kind of prosthetic complication, any problems faced. So that is what proper prosthetic positioning also does to the case.
yes, absolutely. If you have a scenario like this, where in spite of placing the shortest implant, you have to do a lift, but then you realize the lift required would be less than 1 or 2 mm. Current studies have shown there is no need to place any foreign body. The blood clot itself will get converted into the bone. So this is what we could achieve. There is no need to place any graft, no need to spend any extra money, no need of any stress about infection post-operatively. Even if the patient's budget is the same, all you have to do is just tap it up slightly and place the implant. Coming to more complicated case scenarios where role of guided surgery, where bone modification is required. Here the protocol slightly changes. Guided surgery is useful but not a completely guided procedure, wherein no flaps and all cannot be done, because if you need to place a graft, you have to raise a flap. But there are a lot of advantages. You have planned the case prior, you have told the patient prior that there will be need of a graft. We will be placing X cc of graft, so the cost can be calculated prior. We know exact amount of defect we need to fill. We know that our position of implant is as accurate as possible. Their buccolingual position, their apicrestal positions, their mesiodistal positions as well. And we are sure of the prosthesis we can give to the patient before we start. The rest is routine surgical grafting procedures. You do PRFs, you don't put PRF, you put a membrane, follow the procedure, or you do a regular GPR. This is what you have planned, and this is what we have achieved with guided tissue regeneration. Because it was a planned case, again, a cement screw retained prosthesis was given to the patient. Can it be done in cases where narrow ridges are present, or can it be done in cases where a lot of atrophic? It can be done as well. This is again a case where os builder by Ostem was used. It's an expensive whatever, a membrane or a mesh available, but it has a lot of more advantages than the routine basic soft meshes. Here, the biggest advantage was we knew the exact size of the os builder we will require, the exact amount of bone we will require, the exact contour of bone we will require before we start with the surgery. You cannot change os builders during the surgery. I'll use 1 mm larger, one size shorter. They are really, really expensive, much more expensive than the implant itself. So
Yes.
here, if you can appreciate an implant, immediate extraction, implant placement, graft, os builder, and the case was finished.
And look at the parallelism in both the implants, where one is in an extraction socket and one is in the defect area.
Yes. In cases where really, really thin bone is there, or you might require expansion, you can use guided surgery. You do your initial osteotomies, you remove your stents, you do the expansion screws, or you use your piezo reamers, whatever, expand the bone, again put the stent back, and then put the implant, so that when you're putting the implant, there is good control on the implant itself. Can we do it for wrist splits? Yes, we can do it for wrist splits. If you may ask me, why will I use guided once I've done a wrist split already? All the heavy lifting of the surgery has been done. Here, the guided stents were useful to me because I was sure that when I was actually putting the implant, they were not moving within the bone. There is no primary stability when we do wrist splits. In spite of trying to put the implant in a specific position, they tend to change their angle because there is practically nothing holding them. With the help of guides, there is stability on how my implant position would be. Rest of it is surgical excellence, but the final positioning of implant, which is very, very important, is helped with the help of guided surgeries. To crown it all, most people at the end of our presentation don't realize why we have kept this case at the end, why it is important. Because I, as a surgeon, had the prosthesis ready with me before I placed the implant. I planned the case, I put the implant, and the prosthesis is screwed in. Mind you, not cemented. It is screwed in into the position immediately. A prosthesis which was pre-milled before I started the case was ready before I went for my consultation, and the patient was aware that this specific prosthesis will be in my mouth at the end of today's surgery, which was just 20 minutes down the line. Patient walks off with a tooth immediately. A screw retained pre-milled prosthesis.
So yes, imagine for a prosthodontist, it is a boon, you can say, having a screw retained PMMA prosthesis, not worrying about whether it will get detached if you are using a Maryland, if you are using some other kind of a denture or something, will there be buccal bone loss or other things that will happen because of the compressive forces that will come. You have a screw retained prosthesis which is out of function. The patient is happy because it is a fixed prosthesis, and you as a clinician are also absolutely happy looking at the results that you get.
A similar case, 2 implants placed, prosthesis ready. You just screw them in, put a little bit of composite so that to give the aesthetic touch up, and the case is done. So it's not just surgery, it helps you in having your prosthesis ready beforehand. So this is where today guided surgery has come to, where everything can be planned digitally, and we have it not just virtually but in real life in our hands before we start with surgeries,
And
making our
Rahul,
lives
there's
as
one more
simple as possible.
advantage that I would like to mention here. If your temporary prosthesis fits in absolutely the way that you have planned it, and you have this design with you, you can use that same design for your
For the final
zirconia
process.
prosthesis for the final, and
Yes,
you
so no need to
are
make an impression.
eliminating the impressions altogether in this scenario. So if
Yes,
imagine that being happening.
yes. So you just patient comes back, you just remove a PMMA prosthesis and give a final PFM prosthesis. So just to sum it up, the advantages to the clinician, it is flapless, less bleeding, much more precise, no suturing needed, less time required, less time as in really, really less time. I have not done a full mouth case more than 45 minutes surgical time. And when I talk about surgery, it is the time the patient sits on my chair to the time he gets up from my chair and goes to the other room where the prosthesis is done. Not more than 45 minutes. Maybe it's 4, 6. I've not put 8 implants, but even if it is 8 implants, it won't take the same. It'll take the same time. You may eliminate second stage surgery in most cases. For prosthetically, lot of advantage. If you have a prosthetic wife or a husband, I'm telling you, it's the best thing to have because they don't argue with you after the surgery. It's pre-planned. It's their decision. You attain 3D parallelism. It is very, very predictable. It's absolutely hassle-free for them, makes your life much more easier than them. It is very, very passive prosthesis, thus leading to increased longevity. Finally, less prosthetic stresses. Patient advantages. This is where I would like to say, or I would like to give you an advice or caution you. If a patient has done digital implantology anywhere else or even in your practice, they will not get freehand surgery done from you, whatever you try to convince them, because it is minimal discomfort for them, it is minimal bleeding, minimal swelling, so much so that they might doubt if you have placed an implant. Really, really less time, less mouth opening, less inconvenience, less stress. Your sterilization is for sure maintained because it's a shorter appointment. Increased confidence because they have seen what they are going to get, and once they get it, the next time there's no way they will ask you for freehand. I had stopped consulting for implantology because I was planning to move to Canada, but last 100 implants I have placed in consulting was because their patients in their practice came up and said, we want only stents. I had my friend who got it done, and they said that it is very, very painless, very, very fast, very, very neat, very, very sophisticated, latest technology, whatever the dentist might have used to sell it. And that's the reason they insisted that, sir, we do not have the expertise of getting it done. Kindly come and get it done. And I was like, I will come, I will place the implant, I will give you the impression copings. You just scan them, send it to Dr. Pratik at Digital Dentofacial Concepts. We will just deliver the prosthesis and you don't have to do anything. In after I have moved also before this COVID lockdown, there are so many cases which were done in my absence in my consulting practice, and I was paid full.
Nice. So moving on, there's one testimonial that we've added here from one of our doctors who's taking our services for the stents. So we'll have just, it is a audio testimonial. We have a lot of them, but because of time constraints, we have just included.
Hello friends, I am Dr. Ajay Thakur here. I have been practicing general dentistry since 1998 for 22 years now and dental implants since 2006 for 14 years now. Since the start of last year, that is 2019, I have started placing implants using the latest and the most advanced technique of digitally guided surgery. Since then, I have noticed that all my implant patients are extremely happy. They almost have no pain or swelling post-operatively, and I can assure you this because I follow up my patients within 24 hours of the surgical procedure. This holds true not just for a single or two implants, but even for multiple implants, as in for full mouth rehabilitation cases per se. As a dentist, this guided surgery benefits me as well as my patients a lot because these stents are planned and provided to me by digital dentofacial concepts, which are extremely precise and thereby making my prosthesis very simple and accurate. Also, with my experience of 14 years in implant surgeries, I can definitely claim that this makes my patients completely confident on me, and this is reflected when they keep referring more and more patients to me for dental implants. This has boosted my practice to quite a good extent. I totally recommend all my fellow colleagues to make your practice digital and simplify and increase your practice too. I highly recommend DDFC for their fast and prompt services too, where they help you with all the solutions and deliver the guides which are supervised by Dr. Pratik Chheda, who himself is a prosthodontist. Thank you, friends.
Those are quite kind words from him. So yeah, that the main thing that you need to check out in that testimonial is how guided surgery helps you in your own practice. Dr. Ajay Thakkar has been doing implants since a long time, but now he's shifted completely to guided implant surgery since the last 2 years, and still there are a lot of advantages that he spoke of. So, have we learned something new today? Can you please type in yes if you've learned something new today through this webinar? And we have been able to share our knowledge and experience as much as we can. If Thank you so much, Dr. Nishant, for your feedback. But I think there is definitely a lot more to explore. Don't you agree to that? There is definitely a lot more to explore. There are things that you need to understand. Basically, now it is like you're going to shift from a manual car to an automatic car. But still, the automatic car, for driving that, there are certain protocols that you need to follow. Once you understand the protocols, it is definitely a cakewalk for you. It is going to be stress free, plus it is going to be much easier, and you will concentrate on much more important things rather than the clutch, the gearbox, the other things. So if you agree to that, please type in yes in the chat box. And that is the reason there are certain things that you need to further understand and further go through, that is specific protocols for different case scenarios, the different data requirements that you have, the different surgical protocols or the drilling protocols that need to be followed. There are particular things that you need to take care of. Now, for all of this, we want to make sure that you start taking your actions today and start shifting your practice to digital implantology. See, most of us, that is myself and Dr. Rahul, our main motto or main mission, I would say, is to reach out to as many dentists as possible and make sure digital technology, which would give better results and faster results to their patient, next level. And that is our mission, that people start doing it today itself. And for that, we are going to give you a gift today, an offer that is a crazy offer that we will be giving you. With your permission, let me take you directly to the offer. That is, we are going to give an offer where we are providing surgical stents for 10 implants, and we are also going to give you an online course for a complete package that covers the data requirements for guided, that is protocol for partially edentulous, protocol for fully edentulous or complete replacements, guided kits that we need to discuss, that is the normal guided kits, then one piece implant kits, then you have the sinus lift kits, everything with that drilling sequence. So if you are doing a sinus lift, there is a different drilling sequence that you need to follow. If you're doing a normal guided, there is a different drilling sequence, not just the sequence, even there is a difference in the protocol that you need to follow, which is different from the general implant practice. Then most of us want to use these stents for all on four, where you need to take care of the angulation of the distal implant, plus have a better anteroposterior spread. So there is a protocol even for that, with immediate provisionalization, which is our final aim. Today our patients do not have a lot of time, they want immediate results, so immediate provisionalization is important. How you can do it chair side with less stress and not depending on any dental lab to do that for you. Prosthetic considerations, when it comes to the final prosthesis, what considerations with respect to the digital implantology, everything with proper demonstrations done. So our course covers all of this. Normally these courses are spread over 3 to 4 days, where we do it one-to-one, and we charge for a surgical guide. A single implant surgical guide is costing you 2,500. So the entire package here of 10 implants, 10 implants would be 25,000 if you calculate. It is a very simple calculation. The course that we do, we charge 60,000 for this course. So when you sum it up, it comes to 85,000. If you are buying, we are mentors for Austin. We do digital implantology course for Austin, as we are their KOL. And Austin, when you buy a starter kit or you buy implants worth around 2 lakh rupees, it gives the course to you in 30,000. So imagine if you are buying it with implants worth 2 lakh rupees. But what we are doing here is we are giving you that offer even without any inventory. Plus, let me get down to crazier even than that and get down to 10,000 rupees for each tent. Now you imagine, people tell us that we want to start digital, but how do we incorporate that cost in our implant surgery? Because already people might be charging less, it would be different. But when I tell you just spare 1,000 rupees more for the stent and the implant that you're doing, it is very easy to incorporate that. Final craziest offer that I can give you today is giving it with you the online course of for just 5,000, because I want you to understand the entire protocol, and you have come here to listen to us to that to the entire webinar, and we are thankful to you that you gave us a chance to talk and reach out to you, and that is the reason we are giving you this offer. And it is an offer only available if you do it in next 15 minutes. And time starts now, 15 minutes only. You will have the details for the payment links soon on your chat box. Dr. Radhika will do that. She will also take care and make sure that she keeps her eye on the watch. 15 minutes only. By the time, if any of you have any questions, those who want to take the offer can take the offer. It is not a hard and fast, but we can still have the discussion going on, and we can still have any doubts from any of you. We can still clear them off. By that time, if you want to do the payments, you can just go to Google Pay, get the payment done. It is just 2 or 3 steps, and come back here, join us back for our question and answer session. So if you have any questions, you can just raise your hand, or you can just type it in the chat box. So, Dr. Rahul, we have a question from Dr. Joy. When we do a flapless punch, doesn't the epithelium gets pushed down inside the socket? Is it a way of any concern?
Basically, if there is a confusion of an extraction socket, there is no need to do a tissue punch because we already have access. And if it's a healed ridge, then whenever we use the tissue punch, we make sure that we go till the periosteum. That is, there again is a protocol for the speed of the handpiece, the coolant in the handpiece, and there is a tactile sensation that as soon as the punch cut or the punch uh, touches the bone, there is a difference in the vibration you feel, and also the sound of cutting changes. And when you pick it up, you'll notice that the entire tissue is cut in a circular manner and picked up into the tissue punch. It is not that it is pushed towards the bone, it is cut and pulled away from the bone. There are certain kits which provide something called as shredders within the tissue punch, where rather than just cutting a circular ring, it shreds off completely. It's like minced meat. It just eats away that much amount of soft tissue with a very clean cut border of a circle. So there is minimal inflammation because it's like an incision. It's just a cut rather than a straight incision. It's a circular cut.
What in the cases where if it does not come off with the when you're cutting it, if it does not come off in your
No, so why would it not come out? It would be in a case where the thick biotype is there. It's a very good scenario for us if it's a thick biotype. Just take a periosteal and just scoop it out, and you will realize that it comes out completely like a disc. And we'll make sure that in the next presentation we add those photographs as well, just so that this particular question is solved. It's actually a good question because we've not covered it in the presentation, how the tissue punch looks in any of our cases. So it comes off very clean, like, if you wanted to, you could push it back and no one would be able to know if an incision was made.
Dr. Rahul, there's one more question. Which implant companies are presently giving a guided option? And how can we adapt it to the company that we are using right now?
Yeah, so it is exactly like I would correlate it to electrical cars. There was a time where electrical cars was considered to be the future, and today each and every company, including Tata, is making electrical cars. There's no option. So currently, every implant company has their option. They might not be available in India today. From what I know, Ostem, all of the Korean, Ostem, Dentium, Megagen, they have their guided kits available. Nobel has its guided kit available. Straumann has its guided kit available. There are many less common implants which have guided kit available. For that matter, there are third-party kits available in the market like 3DX. There are certain providers within India who rent you these kits also per case basis. Then there are companies which are like interchangeable. You can use a specific kit from one implant company and place the implant for the other implant company. So I don't think there's a shortage of which system you choose. If you have a specific system in mind, you can always tweak any available kit and use it in practically any scenario. Like even if it's a basal implant, you could still use it. So you can use it in every scenario.
Thank you, Dr. Abbas, for that question. Hope you have answered it well. Dr. Rahul, we have one more question. what is the minimum requirement that we need to have at our end to go ahead and start with the guided surgeries?
I would say the minimum requirement obviously is the patient who is ready to pay for the procedure. But other than that, you need access to CBCT, as in the patient will have to get one CBCT done. You will have to make an impression, preferably a putty light body, that is a irreversible material, stable material, and you will have to decide which company you are planning to use, which company implants you're planning to use. So accordingly, that particular kit can be made available to you before the surgery. So even if you don't own a kit, you can have it rented. There are certain companies like Ostem, Megagen, Dentium. They will give you the kit if you are buying their implant anyways, because they want to sell implants. So I don't think getting the kit is important. It is the first step which is important, is to convince the patient to go for a CBCT. If the patient has had a CBCT, you just need to send the DICOM images. You just need to send an impression, and you should just have the kit. The kit, the stent, we courier it back, so that is not required from their end anyways. And I feel the cost to the dentist, if you go with this offer, increases by 1,000 rupees for a single implant, which is practically nothing if you get the advantage of guided surgery, because the
Thank you so
CBCT
much.
the patient pays for.
Thank you so much for that question too. I hope we have answered that question also. Are you guys learning something more? If yes, please type in yes in the chat box so that we understand that you are learning something new today. Thank you so much, Dr. Abbas, for that prompt reply. Thank you so much, Dr. Joy. So any more questions any of y'all have, you can just put in those questions in the chat box. We are still here. I think should be okay. Dr. Radhika is on the timer quite precisely. So we have only 4 minutes left for any of you who wants to take that offer. Apart from that, any questions, if anyone has, we can still go ahead and answer those questions.
They may not be pertaining to digital implantology. Since we have some time, we can discuss anything pertaining to implantology, or I don't know.
How much do you charge a patient for implant, Dr. Rahul?
Yeah, so I mean, I don't have, my wife has a clinic, and I do consultation. So I will tell you two separate charges. For consultation, I charge 7,500 rupees for me going and placing the implant. That includes the planning, the surgical stent. I get all my equipment, including my own assistant. We go, we place the implant, and if the doctor is confident for the prosthesis itself, they finish off with the prosthesis, or my wife or Pratik or any other prosthodontist generally charges 6,000 or 7,000, including the lab cost. And in our clinic, we charge 35,000 for Ostem implants, 50,000 for Nobel implants. We used to do Israeli implants for 25, but lately we have more and more patients getting convinced for Ostem and Nobel, because once you show these things, patient prefers to go for something better rather than something cheaper.
I think, yeah, it's just 2 more minutes now. And any doubts, any of y'all, apart from this, we would also like to introduce something else today. Before that, please make sure that you give in your valuable feedbacks in the chat box. Also, if there's anything any action that you would start taking from today, one biggest thing that you would have learned today and would start uh, incorporating it in your practice, please type it in the chat box. And we would also like to introduce the Digi class. You can see it in the background as well. So we have started with something which we understand is important with the scenarios changing nowadays. We need to reach out to people through digital media rather than dentists reaching out to the trainers. So we can reach out to people, more and more people in different nooks and corners of the country, to teach them and help them better their own practices. So one of these courses that we are coming up with is an upcoming course where we are going to do a suturing course, which is going to be a suturing. You learn 7 different kinds of suturing, which Dr. Rahul himself is going to train you all in, and that is happening live. Streaming is going to happen again on 7th May. It is only for $500, and that is how we are getting more and more into this. We would also be starting with another webinar soon, which would be on veneers. So that is also on track. I think it's just 1 minute, almost the time is up, and we are not also, I think all the questions are also answered. So thank you so much everyone for being a part of this webinar. We have enjoyed every bit of it. I hope you have enjoyed too. Thank you so much for all the feedbacks throughout the webinar. And thank you so much, Dr. Joy, for
Dr.
your
Joy,
feedback.
Stay home, stay safe, and soon we will get through this. We'll have our practices roaring again, and hope we meet up physically at some platform in near future.
Thank you so much.
Thank you. Signing off. Bye.
Bye bye.